Hi, my name is Tiffany Lu. I am a general internal medicine physician and addiction medicine specialist practicing in the Bronx, New York. Today, we will be focusing on discharge planning, optimizing linkage to substance use disorder care, and supportive services. Let's start with a case to illustrate where discharge planning can be so important for our patients with substance use disorder needs. Mr. Smith is a 48-year-old man with active intravenous use of heroin, fentanyl, and cocaine who has been admitted for acute traumatic rib fractures that he sustained during a bystander resuscitation for an overdose. His opioid withdrawal and acute pain stabilized with initiation of sublingual buprenorphine while in the hospital. He was also treated for an aspiration pneumonia. While he is getting closer to discharge, he expressed interest in linking to post-discharge substance use disorder care and potentially even starting long-acting injectable buprenorphine in the future. He was staying at a shelter prior to hospital admission, and he's hesitant to go back to the shelter system. He reports that his cell phone was stolen, and he's not sure how he would make an outpatient appointment. So using the case of Mr. Smith, let's highlight how complex discharge planning can be. Where can we begin? So taking an inventory of Mr. Smith's medical issues so far, as well as his stated post-discharge barriers, we understand that he has traumatic rib fractures with acute pain and he's recovering from pneumonia. He has opioid use disorder that initiated newly on buprenorphine treatment. He's using multiple substances, including an intravenous route, that places him at increased overdose risk after a period of abstinence, especially while he was hospitalized. And he also has homelessness, of which he may become unsheltered homeless post-discharge, and he lacks a cell phone to help coordinate his care. So it turns out that Mr. Smith is not alone. Discharge planning complexities for substance use disorder care are very common. In fact, observational studies show us that there are high attrition rates between the time a patient is referred for post-discharge SUD care and the actual engagement in that post-discharge SUD care. There can be various levels of factors involved, including patient-level factors, clinician-level factors, as well as system-level factors. On the patient end, just like Mr. Smith, patients can have active medical and psychiatric comorbidities, as well as social needs and poor supports. On the clinician level, lack of experience with buprenorphine prescribing on discharge, as well as lack of familiarity with post-discharge treatment resources can be complicating. And on the system level, the lack of protocols and partnerships that facilitate post-discharge SUD care, as well as pharmacies and different treatment settings that vary in providing access to medication for addiction treatment, can all complicate discharge planning. And finally, patients on a system level can experience different insurance gaps or restrictions. So knowing that discharge planning for patients with substance use disorder can be complex, we need to not only take an inventory of the discharge needs, but really map them into appropriate interventions post-discharge. Using the case of Mr. Smith, he is someone who needs acute pain control as well as post-discharge medical follow-up for his issues that he came into the hospital with. In addition to that, he needs medication for OUD access and appropriate post-discharge substance use disorder care. He also needs harm reduction tools and community resources to help him address his overdose risk. And finally, he will need housing and other supportive social resources to address his social needs. And so as we map discharge needs onto concrete interventions that we can pursue, it's also important to take a step back and acknowledge that there are bigger forces at play. And specifically, we're talking about structural forces that require us to be competent about their existence, such as policies, institutions, and systems that shape access to and quality of care for people with substance use disorders. These structural forces can perpetuate historical and current inequities for substance use disorder care, particularly among groups who have minoritized status. And being addiction medicine clinicians, it's important to assess these structural barriers so we can better identify patients who are likely to benefit from additional multidisciplinary health and social services. I want to highlight a structural vulnerability assessment tool that's available for us to consider as we address and assess domains of structural vulnerability for our patients. So now that we have mapped out our discharge planning needs, as well as taking on a structural vulnerability lens that helps us shape those interventions, let's talk about best practices for optimizing discharge planning from the hospital to the community for patients, especially with opioid use disorder. We can start with practical strategies that draw on evidence-based interventions. And what do I mean by that? Evidence-based interventions for improving hospital to community transitions of care for people with substance use disorders include making sure that the patients are started in the hospital on opioid agonist medications for OUD, ensuring linkage to outpatient treatment via available teams such as addiction consult services, pursuing discharge coordination via patient navigation services or peer recovery coaching services, and really looking towards same or next day post-discharge appointment availability for patients who have substance use disorder and other aftercare needs. Those evidence-based interventions can shape practical strategies that we will dive into in the following slides. And then as we work on those practical strategies, it's important to involve hospital and community stakeholders, refine our strategies into protocols and workflows, and then integrate process and outcome measures as well as iterative quality improvement. Now let's dive into practical strategies. One of the key practical strategy areas to focus on is to facilitate post-discharge access to medication for opioid use disorder. In this case, Mr. Smith was started on buprenorphine in the hospital to treat his opioid use disorder and his pain. It's important to optimize that buprenorphine dose. Patients may require up to 32 milligrams, and for patients with pain, they can really benefit from split dosing. For discharge, it's also helpful to prescribe at least 7 to 14 days duration of buprenorphine in order to bridge the patient to their post-discharge follow-up appointment. It's helpful to keep in mind that each box of sublingual buprenorphine comes in a quantity of 30 so that we can better help the pharmacy meet the needs of the patients when we're looking to fill that duration of bridge prescription. And lastly, a practical strategy to facilitate access to buprenorphine is to identify pharmacy partners that can offer same-day medication dispensing. So at the level of the hospital, that means tapping into the hospital's medications to beds or meds to bed program if they are available. Another field to focus on for our practical strategies is to facilitate concrete post-discharge substance use disorder care plans. There are so many different ways we can go about this, and I'll highlight a few here. First, it's important to identify post-discharge substance use disorder care providers in the community and formalize referral pathways. It's helpful to consider different treatment settings that can address different types of patient needs and concerns, as well as whether or not these treatment settings and providers have the capacity to provide acute care follow-up for acute medical issues, surgical issues, and psychiatric issues. It's also important to elicit actively the patient's preferences for those treatment settings, as well as potential constraints for attending a post-discharge substance use disorder program or clinic. Next, confirming the contact information for the patient and/or their emergency contact, especially if they don't have a working cell phone, is very, very helpful as we obtain post-discharge appointments to provide that information to the aftercare provider. And when we obtain those post-discharge appointments, it's helpful to look for short wait times and/or places that can offer telehealth. When we get those post-discharge appointments, we need to communicate clearly with closed-loop communication methods with the patients. For the hospitalized patients, On discharge, we can provide that in writing in their discharge summary through the patient instructions, as well as printed flyers and business cards for the patients to have in hand. And finally, even after the patient has left the hospital facility, it's helpful to conduct post-discharge follow-up calls to really ensure that linkage to care loop has been closed. Let's talk about practical strategies now to provide harm reduction tools and community resources to the patient prior to discharge. Recall that Mr. Smith is at high risk for overdose due to his multiple substance use as well as intravenous drug use routes. So Mr. Smith, like many of our patients for substance use disorder, are at high risk for overdose post-discharge, especially after their period of abstinence. And in the hospital, we are very much at a great place to intervene with harm reduction kits. This has been described in the literature as implemented by hospital-based overdose prevention programs, as well as through addiction consult teams. These harm reduction kits can include overdose prevention education resources, naloxone medication access, fentanyl and other drug test strips and accompanying education, flyers and education on never using alone, local resources for syringe services, harm reduction services, and mutual aid groups, and finally, additional information and potential tools for safer use of specific substances that the patients are using. And diving into naloxone medication access, we have a lot more literature on practical strategies to do this. We can partner with local health departments to dispense free naloxone take-home kits if it's available. And even at some institutions that have absorbed the cost of naloxone, to be able to partner with local hospital pharmacies to do this can be really important. Or prescribing naloxone to the hospital pharmacy so that it can be dispensed at the bedside, or prescribing it to a nearby community pharmacy so the patients can easily access it immediately post-discharge. And finally, training our hospital teams beyond the addiction specialist to provide overdose prevention education can be really helpful, including training the pharmacy teams and nursing teams to do this at the bedside. Shifting gears from harm reduction-oriented practical strategies, let's talk about how to enhance post-discharge supports that address structural vulnerability. We can focus on 3 routes of practical planning. The first is to formalize referral pathways between hospitals and services such as medical respites that work with people with post-discharge subacute needs and also provide temporary housing, shelters, and other homeless health specialty providers. We can collaborate on discharge planning with multiple disciplines beyond traditional hospital social work or post-discharge substance use disorder programs by partnering with peer navigators and or community health workers. And we can utilize resources that may already be offered through insurances and payers and state and regional agencies. And I want to highlight comprehensive care management programs, health home programs that might already be available through your state Medicaid, medical transportation services available also through Medicaid, as well as other regional and state agencies, and finally, state ombudsman programs that might have available phone resources or online resources to help patients navigate through different post-discharge substance use disorder and mental health care needs. So now we can think about Mr. Smith and wrap up our key takeaways. We know that someone like Mr. Smith is not alone in the complexity of discharge planning needs for someone who is experiencing substance use disorder, as well as other acute medical issues and social needs. There are multiple patient, clinician, and system factors that can contribute to the attrition rate between treatment referral and linkage to post-discharge substance use disorder care. So we need to take inventory of discharge need as an important first step, and to integrate structural vulnerability assessment as a helpful way to address disparities. Optimizing discharge planning starts with practical strategies that we've reviewed, drawing on evidence-based interventions. particularly to improve access to medications for OUD, facilitate linkage to substance use disorder care, enhance access to harm reduction tools and resources, and helping patients access resources for structural and social supports. Thank you.